position of 58.7 for this year, to accept the Deloitte's deliverables, which we set out, which will help us secure a sustainable and financial balance. And to note that Deloitte have set out what needs to happen. What we are now doing as part of our AMTP refinement is working out how and when we as a board will agree to implement some of those recommendations. Happy to take any questions.
Sounds good, Ben. And Pat, do you want to come in on the PFC view on the month 11 position?
Yeah, sure. Thanks, that Claire. So yeah, PFC acknowledged that month 11 position with an underspend of 0.1 million was the best result to date. The year-to-date position 57.2 million. But as Claire noted, the main reasons for this were largely non-recurrent windfall items rather than an increasing nature of grip and control. So the confidence in the Health Board's ability to hit the 58.7 million deficit is increasing. It's looking far more likely, but there's been ongoing concern about the over-reliance on non-recurrent opportunities to deliver the position, and obviously we've seen the impact on that in 26. 27 is about 32 million pounds in saving shortfall. We've seen that actions are being put in place to improve financial grip and control, but the Health Board isn't there yet and still had work to do, which was evidenced by variable pay is still running far too high at 4.4 million in February, despite all the work to date. And it's going to be very critical to strengthen the grip on this as the Health Board moves into 26, 27. So we're concerned how we move into April of next year, how that can be stronger, stronger monitoring in regard to that. And of course, underpinning that as well, it's how we impact and control sickness, as we've seen earlier today. So, and the other aspect about grip control is that lack of delivery of savings plans, either from September or December, in terms of recurrent savings.
The other PFC members? Rina, do you want to come in?
I was just going to say the other point, I suppose it links to next year, but in a way of how are we lined up now to commence work in April. And that was a worry we had because of the nature of the number of non-recurrent issues that have come into last year, that we are up against an even bigger challenge to find recurrent to next year.
So that's how does grip and control continue now into quarter one, month one, Claire?
Yeah, you're absolutely right. So there's two things that will come into play in quarter one. One is that we will retain the additional actions that we agreed as an exec team and board in terms of pay and non-pay, and we've got the scrutiny committees up and running, and those weekly trackers are shared with the exec team. The other bit for me is the implementation of our new budget setting, which will re-baseline budgets, which will include an allocation of the deficit, but it will also include the allocation of the 65. So we'll have greater transparency in terms of where the pressure or where the non-delivery really sits, and we can really tackle that. The other bit is we've instigated a weekly detail tracker on the PID completions. So we've got a level of maturity for each of those PIDs, which will show that there are some areas that will be more ready to be implemented. A lot of those will require refinement and finalisation. But the reality is that will be compensated for the fact that the budgets will already be allocated to the relevant budget holders. So there is greater grip and control. The reality is that pressure on delivery is still there, and hence the need now for us to really focus on getting the delivery unit up and running to support the delivery of those plans.
Steve?
Yeah, and the other concern we had was, month one starts next Thursday.
Yeah.
And so, and these savings, 65, 66 plus 19, we've got to find. They've got to kick in immediately. Otherwise, you don't get the full year benefit.
Yeah.
And if we're still talking about PIDs in 1 or 2 months' time, we're going to fall behind the run rate again.
Yeah, and you're absolutely right, Steve. And I think that maturity tracker really indicates the one where we need to focus in order to get those PIDs done and completed. The other thing is the controls that we're putting on for pay and non-pay will will by default deliver some of those savings anyway. So it's really balancing the need to have a more tactical plan, which may be later in the year, which may mean that we have to have a bigger pipeline because the current pipeline falls short because we haven't delivered the full year benefit. But the key to it then is maintaining grip and control of our pay and non-pay through those processes that we've instigated to balance the offset. But it will be challenging, and we do need to compete.
Any other comments? Clearly, all is coming through the recovery and sustainability board anyway, isn't it, in terms of, you know, the grip and control, the population of the PIDs, etc. So, you know, keeping that focus. Yeah.
And to add to that, we've got a really clear way, and I think it came into the board session when Deloitte joined us, around how we assess that maturity, Steve. So we've got quite a lot in the pretty well described plan. It's the bit about transacting into the budget. And I know since we met, you've been working really hard with Deloitte and Sam and team and the finance business partners to make sure that the budget setting approach and how we transact the savings through is really clear where we would expect them to fall out, because then we could be supporting through the exec sponsored and exec led programs and service group program work where the funding falls out.
Richard.
It's probably worth acknowledging the impact on staff in the sense of the additional controls that are in place clearly have an impact on day-to-day activities. And that's why it's really important we've got the context right in terms of explaining why we're doing that. We are explaining this is about giving us the breathing space, as Claire said, in terms of so that we go into next financial year where we're not on the back foot like we were this financial year. I think staff will probably appreciate us acknowledging then that it's not easy right now in terms of the controls that we put in place, but the necessity to do so given the financial position that we're in.
Richard, we can pick that up as part of ongoing discussions on the annual plan. Well, yeah, point well made. So can we move then to the recommendations as Claire has outlined? I particularly want to draw your attention to the recommendation around the Deloitte team deliverables. So we are clearly accepting the Deloitte team has really given us what needs to happen. What do we need to do? We have some further work to do on how does this happen? When does it happen? What is the timeline for it, given the operating context within which we're working? So I think that is a really important minute. So are people happy with that minute as it stands? Because we're not accepting that we can implement everything in full in the timelines the Deloitte team has set out, because our operating context militates against that. People content with that? Thank you. Maria, I think we will have to come back.
Yeah.
To creative performance then.
That's fine.
We do.
Yeah, so if we can start on. So I would suggest we start on page 224, which is section 2 of the performance against the health board's strategic objectives. It has the national targets and our local targets as part of that slide deck, so we can run through and pick up areas where we're in escalation, either in terms of enhanced monitoring or targeted intervention. So if we start off, Jill, are you happy to take us through the vaccinations?
Yeah, sure. The people of Swansea Bay living healthier, equitable and more prosperous lives. So the organisational strategy indicators are percentage of children up to date with scheduled vaccinations by age 5. We've gone up, but still not hit the 95%. We have maintained on the HPV vaccination by the age of 15, but we're still leading in Wales. The percentage of adult smokers who made a quit attempt is 3.5%, so short of the 5%, and that target will increase, I understand, going forward. So trying to understand with Megan, but I think it might even go to 10% that they require. The bowel screening is looking better with 64.2%, but it's a very low aim, 60% for uptake from bowel screening. We would like that to be a lot higher. The percentage of adults 65 years and over is not where it needs to be, and that needs to be improved next year. COVID is even worse, and there is just fatigue, I think, over the COVID vaccine, and perhaps, if those two programs were able to be delivered together, which at the moment is not the case, then that would mean at least we could get, the 68% for both. That's a national thing, but the really pleasing thing is not on this table, and just to report two things to you, that the staff vaccinations have gone up, and they've gone up from 32.9 to 43.1. So that's an increase of 10% in real terms. Not so it's a really fantastic achievement, and I think it's testimony to all our peer vaccinators that got involved, and also to many managers that let them. Many of those were nurses, allied health professionals, and people were really helpful as well with venues this year, finding us places to go, and people came forward. So Richard, it was a really good comms campaign, I think. So there was a number of building blocks that have led to a 10% increase. Really, really gratifying to see. And then also pleased to tell you that our flu in pregnancy, we always track equity on everything, and we're the first health board in Wales where we now have better uptake in our more deprived areas than we do in our affluent areas. So that is showing a bucking of the trend. So that's also really pleasing to report.
Thanks, Jill. If I take board colleagues now through the next section of the report. So we've got the summary slides for care is high quality, safe, efficient, and delivers the best possible outcomes for people. We've got a couple of summary slides there. If I move you through into detail, so if we go into unscheduled care on page 231, that provides an overview of the position that we are currently reporting in terms of our key performance under our 4-hour and 12-hour waits. It is disappointing to note that our performance in terms of 4-hour and 12-hour waits is deteriorating. It is a symptom of the pressures that we've got in the system that have we've continued to experience since Christmas. There are a range of actions in place. And one of the things that we're doing as a wider exec team at the moment, if you move on, Jake, to the unscheduled care slide. Move on. That's it, next one. Super. So it does show that we have a deteriorating position with our UEC measures. We have increased demand from WAST that has continued through March, and we have reduced some of the surge capacity in the emergency areas, but we still have our full your next patient capacity deployed, and lots of work going on looking at how to facilitate discharges at the back door. We've just agreed with our PB colleagues to extend some of the intermediate care bed capacity in Godalming to facilitate some of our pathway to discharges because of the exceptional pressures that we're still incurring in the system. So you can see February's position is a difficult one, and you can expect to see that continuing into March. As a full exec team, we are meeting with Morrison and colleagues tomorrow again to look at, are there any urgent and intermediate actions that we can take in order to provide support. It is a whole system issue, and by whole system I don't just mean community colleagues in the local authorities, I mean from a primary care perspective and from a hospital bed flow perspective. So we're looking at some urgent interim measures that we might take in terms of how we manage our patient flow teams to try and look at how we can get better flow within the hospitals, within those beds, as well as out into our communities. So it is a very difficult time in the urgent care system currently, and the data that we're presenting through this report underpins it. But be assured that there are multiple actions underway to address. Can we move forward? Marvellous. And clearly that is impacting on our ambulance handovers, and we're again working closely with WAST, working closely with the SPOA to try and mitigate the impacts for that. If we go on to stroke, we've had an opportunity, I think, to rehearse some of the constraints and issues that we are facing in the stroke service. And there is ongoing work to look at how we can strengthen and improve the pathways. And I think it is worthy of a deep dive or an IM session, again, just to run through where we've got to and what the opportunities to continue to improve may look like. We move into planned care. More a good news story. Teams have been working really, really hard to ensure that we continue to get that improvement trajectory. So I'm pleased to report that we will meet our targets in terms of reducing our outpatient waits, as well as eliminating our over 104, keeping our 104 wait patients down. We did report, I think, 5 waiting over 104 weeks in February, but that was a result of the orthopaedics supply issues because of the cement shortage. But we think we should remedy that by the end of this month. That remains our target. Next one. And again, finally got the endoscopy unit up and running. So seen a really good improvement in performance to reduce our over 8-week waits for diagnostics. And we will have a 0 wait also for patients waiting over 14 weeks in therapies as of February. We have seen a small reduction in our follow-ups not booked. I'm not sure if it shows in that slide. There has been a lot of activity trying to look at new ways that we can validate and reduce our waiting times for follow-ups, and that still remains an important priority. Mental health and LD, again, we've talked about the gap in the service provision for psychological therapies. We're working closely with Welsh Government colleagues to look at how we can work to develop a solution on a national basis, whilst we look at some of our local opportunities within our own footprint. We move on to the CAMS. We're just off the 76% target for February, but we are continuing to recover the trajectory for undertaking the number of therapeutic assessments in 28 days. We are still a way off being able to provide the level of service to meet the target for NDD, but I think you've just had a letter in from Welsh Government colleagues, Abby, saying that there will be more funding made available. I think the issue is that, which is good news, as it will give us additional capacity that we can put in place to bring down some of the weights. But I think it is just a bit of a finger in the dike in terms of having a long-term sustainable service for this cohort. Next slide, please. Theatre efficiency. Again, still a long way to go. This will be a programme with which will come under increasing scrutiny as we implement our planned care programme for next year. So there is a huge amount of support that we've actually had from Deloitte's colleagues in helping us model what we need to do. So we will start to see slow improvements that you'll see in January and February in terms of theatre utilisation, and slow reduction in terms of the number of late starts, and a reduction in the number of early finishes. So early green shoots, I would say, but still some way to go. Fractured neck and femur, the performance in some of these arenas suffers from the same pressures that we've acknowledged for stroke services, in that ring fencing capacity can often be challenging for our fractured neck. We're on the wrong. Can you move on to the next slide, Karis? Thank you. So we are still operating under target in a number of these areas. I don't know if there's anything, Raj, you would want to pick up in terms of the clinical indicators.
No, I think the fact is that, our time to theatre is actually something that we have noted. And I should say very conscious of that. But at the same time, the one thing we keep an eye on is actually also our mortality rate. And that's actually that's never been a problem. But that doesn't mean that we should be getting out. And that again goes back to the conversation we had with the stroke. It's actually a very intense bed and basically getting people into the theatre at the right moment too. But again, the fact is it's actually a weekly data that's actually been monitored regularly.
Thanks, Raj. Moving on to primary care, again, in terms of practices in escalation, that has remained fairly steady throughout winter, which is a pretty important indicator. Seeing a steady increase in terms of the patients accessing the common ailments scheme, which if it continues is a 17% increase on last year, which is again something that we need to keep as we're planning our community by design interventions for next year. Moving on to quality and safety, who's picking up IPC?
So I think from the top left-hand corner with regards to CDIF, it's actually not reflected there, but we have actually had a 24% drop in the CDIF rate compared to the 24-25 data. So it's actually a significant drop with regards to it. So, but at the same time, we are still not reached that will come out of the targeted intervention. So it's actually going on. To the extent that it's been so good, people have started coming for the CDIF high incident management group to step down. We said no, because we need to actually carrying on with regards to bringing that down. And the fact is, what we have been reflecting is what really made that change. Because the fact is, I do think it's actually because the flow has been a problem. So it's actually the fact is we actually have the HPV basically there. We actually did have make sure that the clinic was actually going through, but also the fact that the switches to antibiotics from IV to oral, making sure people are actually being followed up. We used to be an organization which used to prescribe Tazocin. Tazocin is actually a broad spectrum antibiotic. So when Tazocin is not prescribed, people are actually jumping on each other as to why it's being prescribed. So it's actually really making sure that's actually being targeted. It's actually there. With regards to all the four, the Staph aureus, again, it's a good progress has been made. Klebsiella, again, good progress has been made compared to the last year. The only, it's actually not reflected on this particular chart for E. coli. There has been a bit of a blip. So we are actually doing quality improvement with regards to primary care, especially from an E. coli perspective. So just making sure that's actually going on. So from action perspective, we see that is the whole command is we are actually making sure that the antimicrobial stewardship, which is actually going to be very crucial, and 72-hour switches is actually happening. And as I mentioned, it's actually the QI projects with regards to urinary tract infections in care home residents is happening too. And the fact is, we did actually have a hospital-acquired pneumonia audit before, and that's actually stopped, but we have actually restarted that again. So once that comes through, I'll make sure that it comes through QSC as part of the healthcare as part of the advocacy about to QSC. Okay.
Next slide, Karis. Brilliant.
Karis, I'm sorry, I won't be. Slides will go, but I'm just going to pick out a few things that I need to highlight really. From a patient experience perspective, overall the feedback that we get is positive, with around 93% of patients saying that they had a good or very good service with us. The national target is 85%. So despite the acuity, despite the challenging times that we are working in, we do have quite positive feedback. However, our complaint response times, although they are improving, we still have more work to do to consistently meet the 30-day target. And of course, we're still working through the outstanding complaints that we've had over some time. We've redirected resource into that, and that is having an effect, not fast enough, but We're going to redirect some more. We want to be ready for listening to patients to commence from the 1st of April. We've already started to trial different ways of working in Singleton, Neath Talbot and Morriston. And actually our complaints department from last week have been trialling when somebody rings in to raise a concern or an issue, they used to get an answer phone. Now they're getting a person. So we're just going to start evaluating that. It's very early days and we've had to redirect resource. But for me, if you answer the phone and have a conversation, you're going to hopefully get an earlier and a better resolution. And that's the whole premise of listening to people. And as the chair said, I'll bring something back on that through QSC. Our pressure ulcer rates, our reporting is really good. We know that. We've had reductions. However, I have to say in the last couple of months, our pressure ulcer incidence has gone up, predominantly in our hospitals. And when we're doing our learning from it, we believe that is related to acuity, to the frailty of our patients, and also the fact that our hospitals are full and sometimes we're nursing patients in areas that are probably not the most optimum, plus we're having delays in transfers of care. So that we believe is really driving that. We've had a 23% increase in our hospital pressure ulcers, but we're going to do some more work into that and we'll bring it into QSC. From a falls perspective, we continue to be below national average and we're the lowest now per 1,000 bed days than we have been since June 23. So some really good work going on there, and it's not just in the hospitals, it's outside as well. The biggest reduction has been seen in Cefn Coed. Lots of work has been focused there. Falls admissions to MIU has gone up by about 20% and ED attendance at falls has gone up by 7%. We have had 4 nationally reportable incidents around falls in the last 12 months. We'd had 12 the previous 12 months. So the work is really impacting around education, training, assessment, but also the deconditioning work that we're doing across the health board. The care home project is live across 15 homes in Swansea now, and we're prepping with all of the other homes to roll that out. And our aim is to reduce the ambulance response, bringing in patients from care homes into our hospitals. So more work to do there, but we're on track to reduce that. We want to see a 30% reduction overall. I think that's all I wanted to highlight. Thank you.
Can I just ask a very quick question? In terms of the falls programme aligning with the RPB work, do we actually have a vehicle for doing that now? We do.
We work across the whole system and it's led by, predominantly by Larry Darcy and the quality safety team, but we do have a system-wide approach. But if there's anything more we need to do, Marie, we can.
I'm not sure how visible that is
Okay.
within the RPB leadership, so that it would be good to bring that into the communities and older persons programme forward, just to report what's happening in the health board, Craig, and there's an opportunity then, isn't there, I think, to say what can we do together? Are we duplicating anything? Are we missing opportunities to join things up? Thank you. Okay, next section is, do you want to pick anything up on mortality, Raj? The last slide on that section, page.
I should say the fact is, no, from a growth mortality perspective, we don't have any particular issues. I keep an eye on the 4 condition-specific mortality rate, that's sepsis, MI, and stroke, and fracture and femur. I haven't got anything that's actually out of the loop. The one that you see on the bottom is actually the number of ED deaths in the ED. Have to say, every winter we do actually see a bit of an excess death we haven't actually seen. So I should say that I still wait for the data completion. So early for me to comment on it, but still the trend is actually reassuring so far.
Moving on then to maternity and leave days. Is that back to you, Liz?
So I'll pick this up in the perinatal committee report because it's all covered in there.
Yeah. Okay, so should we move on to digital, Matt? You want to cover that? What was it about days?
Thank you. So we're still not where we want to be on discharge. Sorry, we have the slide with stats up.
258 carats, if you whiz through.
So we're still not where we want to be on the discharge, electronic discharge letters sent to GPs. And also a stat that's not shown here is our outpatient clinic letter performance as well. We know we've got some backlogs there, so a key focus for us now and moving forward into 26, 27 is to address those issues, particularly with more digital tool support. On digital inclusion, you can see that the uses of the patient portal and the NHS Wales app, which we've got seamlessly working together, continue to increase each month, but we really want to take that now to be in business as usual and how we work with the organisation so that we make that the default way of working and how we interact with our patients. On diagnostic requesting, clearly we're doing very well with pathology test requesting. As we now introduce the new radiology systems, we will see the statistics for radiology increase, and we'll be adding those stats to this page as well. And in terms of our estimated data discharge recording, clearly that's languishing at 42%. What we're trying to do from that stat is give an indication of how digitally mature our staff are across all the wards in using the systems we're providing to them. Whether that's the right stat we've chosen, I don't know, but we'll be working through with the wards and managers across the piece on that. Next slide, please. From a performance of our systems perspective, we're clearly doing very well with uptime. And obviously, as soon as there's any loss of systems, that causes issues right across the organisation, hence the need for us to continue to be on top of our business continuity processes across the organisation. And from a data-driven organisation perspective, the number of staff that we have going through our digital intelligence courses is increasing all the time. And as we form the delivery unit and the BI and performance coming together, that's going to be a key aspect for us. Next slide, please. And just to cover off the two reds on current projects, I've already discussed LIMS earlier. And from a Welsh Emergency Care dataset perspective, we've currently got a business case that we're developing locally to determine the best way forward for us to support UEC.
Thanks, Matt. Sharon, would you like to pick up workforce?
Yes. I used it. So in terms of PADR, we know that we're not quite where we need to be because the target is 85%, but it's currently 75.79%. There's lots of work that's going on in terms of that respect. In terms of staff demand, we're above the target, which again is 85%, but it's currently 88.54%. In terms of sickness absence, we have actually seen a slight reduction in terms of sickness absence, and we've currently got a rolling sickness absence rate of 7.2%. And there's a huge amount of work going on in terms of sort of sickness absence or attendance. We could spend the rest of the meeting just talking really about that. And in terms of the main reasons, it tends to be stress, anxiety, and depression. And currently, our long-term sickness absence rates are 4.39%, with a short-term sort of sickness absence rate of 2.81%. Right? I think that's it. I think that's it for me.
Thanks, Sharon. And then we have the revenue position, but I think it's done a full assessment through this paper. Did you want to go through the service specific? So we've got cancer. Craig's back. He can do it.
I think there've been a number of questions from IMs around cancer care and targets. So we've moved back from 80%, haven't we, to 60%, I think. So can we just understand what is happening on cancer care, please?
So in terms of the, just to be clear, in terms of the target is 75%, the 60% target is the target that we were set by Welsh Government in terms of de-escalation. So the target in terms of de-escalation is to meet 60% in 3 consecutive months. Yeah. So that's different. So the target hasn't changed. It's just, there was just that sort of clarification.
So where did the 80% by March 26 come from then?
So I think there was an aspiration, it's an aspirational target from Welsh Government to get to that level. But for us as an organisation, with de-escalation, it's 60% for 3 consecutive months.
Just how do you want to pick up, because PSD looked at this, didn't they?
Yeah,
Didn't you,
yeah.
Anna?
I mean, there are a number of service areas where PFC this month has noted consistently poor performance over the last 2 to 3 years, and they'll come through in the next 3A's report. But yeah, particularly on cancer, we do fluctuate even around that 60%. That's to the TI aspiration. It was 55% in January, but noting that may increase a bit when the pathology results come through, whatever, it might go back up. But yeah, there was some concern about, but we were a lot lower than our own internally set targets, the trajectories we set, which is the 80% by March. And I think on backlog as well, we were 314 and the trajectory was 99. So ongoing concern about performance there. Did you just want it in relation to cancer?
Do you want to come back on that, Craig?
No, I mean, yeah, as I said, we set a trajectory to, Raj will come in. We set a trajectory for us as an organisation. That's both for the backlog and for the improvement. The backlog will vary because it varies through the year depending on some of the specialties, particularly dermatology, skin cancer, where we get peaks and troughs. But no, certainly we're not where we want to be. And obviously Raj has oversight from a performance
perspective. Actually, we actually did a workshop about 3 weeks back with all the clinicians, and basically not looking at cancer just as a system-wide approach from primary care, from prevention perspective, so the whole thing. And the whole purpose of the workshop was to look at agreed work streams with the clinicians and also to look at clear system priorities. And the plan is to basically have a 90-day plan with regards to it, which is already started. So there's actually a real focus with regards to how we actually deliver cancer, because, and I should say, the fact is what we are actually not focusing on that, not just on the 62-day delivery target, is also beyond that too. So that work has already started. So it's only a couple of weeks, so I just need to see how that translates.
But I think we picked up quite a lot of the advisory notes from PFC to the board. But is there anything that we haven't picked up on? We've done cancer, UEC, we've done healthcare acquired infections, diagnostics, we've covered mental health.
But on plan care, I know you noticed the kind of fragility that unless we get the additional non-recurrent funding in 26, 27 we've seen this year, then there's questions over the target. It will be really good to see what our performance is within core funding, and especially as if we can improve efficiencies, etc. And what that looks like. And we've said the same about UEC as well, that it depends on non-recurrent funding coming through. But we are reviewing all of the investment in UEC, significant investment. So it was just how those things played through, really.
I wonder whether the committee has a look at that, because we've got detailed work. And I think it'd be really good to look back and understand across the specialties, what was delivered in core, what did we, and it's a combination, some was insourcing, so it was a blend, where some of our staff contributed and we had colleagues coming in, and others were directly outsourced. So I think a summary of what we delivered last year and how we delivered it, and then looking forward, there's quite detailed work, because in effect, we've got 3 specialties. Craig, I think it's orthopedics is our biggest problem, that we are not alone in that. Urology and gynae and max is other problem specialties. So understanding what the gap is. And of course, this is just looking at sort of the treatment end of the pathway. There's something about looking at the whole pipeline, because as you know, we look at stages gone right way through, and looking at what we've got waiting at each stage. So I think it might be useful to do a bit of a deep dive. plan care gets over all of this, but I just wonder whether it would be useful. I think it would be helpful to understand where our pressure points are.
Yeah.
So across the pathway.
Yeah, have we remit that to PFC?
Yeah.
So I think the other points have been, we've talked through them. So Craig, just one final point before we conclude. Just asked if you could assure the board what happens in relation to those clinically optimised patients for whom a healthcare, an NHS required intervention is needed, not from partners, but from ourselves, so that we are not contributing to any delays. So can you just talk the board through, assure us, what does that process look like, please?
So, I mean, from the daily ward rounds and the board rounds, we identify whether there's any requirement for any diagnostic or therapeutic intervention for those patients. We also periodically do, as we've done today, and as we did when Raj and Liz went to Morris a couple of weeks ago, we do a patient in the bed audit, and we look at every patient and record the reasons for the delay, why they're in bed, and if there's anything that we've missed. I think on the day that Raj and Liz were there, I think there was one patient maybe we'd overlooked, was waiting for the result of the CT. So there's that level of rigor day in, day out to make sure that we are not contributing to those delays.
And are we confident then?
So we're confident from the work that's done around for the rounds and the wardrobes. And I think some of the issues is that when we take a snapshot and we record the number of delays pending care, and we'll have a figure. So let's say we have 40 or 50. Those may be the 40 or 50 patients who are at 40 or 50 of the 80 or 90 patients who are actually going to be discharged on that day, or are actually having an intervention that day that will actually facilitate their discharge. So that's where some of the confusion may arise.
Liz, do you want to add to that?
I mean, Jean will probably come in as well, but we have looked at this at QSC. What I suppose would be really helpful is a bit like we want to do with stroke. So let's see some actual patient kind of scenarios and real patients to show us where those delays were. And so we have got all of that information, I'm sure. I think we need to look at it from the patient's perspective and what does stop our patients actually leaving hospital from those health care related, over a period of time.
The 3A's report actually picks that specific point up. Our concern is that from a risk profile, we can't see always where the risk of that putting a patient into a surgery or next patient bed is actually undertaken. And that then dovetails into the information that we glean in terms of the numbers of COP patients. There's more work to be done there. So you'll see on the 3A's report that we're having a deep dive into COP at the next committee meeting.
Thank you. And I think the use of case studies, and it's a very good tool, isn't it, really, for assurance purposes. So thank you for stepping in there and stepping us expertly through. Abby?
Just a look ahead. One of the things that Welsh Government has now produced is an all Wales dashboard on all of the metrics that Welsh Government track. We have got additional ones, and the intention is to give you access so that you can basically, it's got all of the quad aims and all of the measures and all of the organisations, so you can see how we compare. The risk is that you get a bit distracted. But I've been doing, where does Swansea Bay compare? So I've been having a look. And some things we do well and some things we do less well in terms of comparison. But I know that one of the questions you've all been asking is, well, how do we compare? We just want to work out the best way of giving you access to it because it's in a live dashboard. The trouble is it's behind our data. So a number of the things that are being recorded, we've actually given you more up-to-date information. I don't quite know why that is, but and we'll find a way of, and even if it's linked so that you can Put it in the reading room, perhaps we'll put it in the reading room.
Put links in the
Yeah, yeah.
IPR report.
Yeah, and then at your leisure, you can look at, because there's some really good stuff in there, or looking at it before and say, well, actually, we compare really badly, or actually really well in some areas. So just to flag that is now available.
Oh, thank you, Abby, that'd be really helpful.
Might want changes for our own data as well.
Yeah.
So I was talking to Meg about it. And I think it'd be useful if we did have a board development something on the data.
Yeah.
It's not all of us are as comfortable with that kind of statistical analysis and on the IPR generally.
So I thought, so Pat, Marie's got a new member of staff joining the team to do as part of the Organised for Success, and so it's a short-term placement, but to help us have a refresh and a look and some of the modelling that we need to do going forward. And I think a fresh pair of eyes on our report. I think our report's really comprehensive, and it's about, for me, I like the fact that it aligns to our strategic objectives. So there's something about, we need to have something that fits our organisation, but we do need to cover off some of the national data. And I think I shared previously, and if I haven't done, I will make sure you had it. There is a refreshed performance and accountability framework from Welsh Government that describes escalation and changing all of our meetings. So Jets, our joint executive team meetings go, there are different escalation meetings coming in. So we could probably do with looking in the round with our own internal performance and escalation framework as well.
Thank you very much. So we're given, I think, this item full consideration. We've acknowledged what the different performance is against our key measures and targets. We've taken assurance on some aspects. We've looked for more action and more deep dives on others, which we'll reflect in the minutes. Now we're going to do a little bit more of juxtaposition on the agenda. So we're going to move to 4.6, but 4.62 first. We're going in reverse order for 4.6. So Denise,
Sorry, I quite missed, were you introducing me there? Sorry, I missed it.
I said, croeso nôl i'r bwrdd. Welcome back to the board. Thank you. Thank you very much for your time this afternoon. We apologise for keeping you waiting. We've got a wide range in agenda today, so we're a little behind. But very welcome as always, and we'll take your report first, please.
Okay, thank you very much for inviting me. Hope you can hear me okay. And I'm assuming that you haven't had the perinatal committee report. Is that coming after me?
It is, so that we don't keep you waiting, Denise.
That's fine, no problem at all. So just to update, and you've got my paper from the oversight panel, which we met on the 23rd of February. So I'm going to take the paper as read and just kind of highlight a few points. The panel met to look at the latest version of the oversight panel, of the improvement plan. We also reviewed the perinatal committee paper that went to the last board and providing some comments on that. We're also planning an event which I'll come to. So in terms of the improvement plan, there is still a little bit more work to be done, and I think it's helpful because it's timely and it gives an opportunity to incorporate the output from the All Wales maternity assessment review. Because the plan really on the improvement plan is that it is your plan and that it will be, continue beyond the life of the oversight panel, who will look to be finishing their term in the autumn. And there's an opportunity, I think, to incorporate some of the Wales work into that so that you don't end up with two separate plans, which we think that would be helpful to you. So just in terms of feedback more generally on the plan, the areas that we think needs a little bit more work are around the patient community, the family and the women and the kind of involvement and experience part. And we have had a meeting with your chief nurse and others around some suggestions, particularly the work that Ken Sutton is supporting with the team around a way that maybe that could be structured, which will help, I think, in terms of perhaps separating experience of the women that are currently utilising your services from the plan around the mapping and the involvement. So we've made some suggestions. I think that meeting, our suggestions were well received, and I think a little bit of the way that's written would be incredibly helpful going forward. Particularly as some of the issues that arose from the review was around direct feedback and whether the mechanisms currently capture a wider group of women. The second area really was, and that's alluded to in the perinatal report and in the All Wales review, is we can see that there's an overall increase in the caesarean section rate that's happening across Wales, happening across England as well, but that does have some capacity issues around theatre capacity, but particularly around postnatal care. And postnatal care was a key part of the review's feedback as well. The other part of the All Wales review, which I think is helpful, is their relationship towards the improvement in outcomes more generally for Wales and the way population health feeds into that. And then finally, for the improvement plan, what we're looking to see is a little bit more detail around two-site working. We can see that there's been a huge amount of work done around some assurance around obstetric admissions to the intensive care unit, but generally the challenges that two-site working poses to you, more for women in every part of your second site, particularly A&E medical surgical wards. I think there's a little bit more to be done there. And we can see that there's been a recent case that's in your perinatal committee of a woman having her baby in the emergency department. But there's an opportunity, I think, to look at what's learned from that, although that's been very well managed. What are the potential risks of that going forward, and thinking strategically around your influence around the future of two-site working, outreach, etc. So those were some of the feedback that we gave. I have to say, overall, we feel that all of the reports are significantly improved. The perinatal report looks much improved this time. I think that's an opportunity for the board to see the action and the progress that's coming out of the improvement plan. So up to a point, the improvement plan will always be iterative. The other thing we have suggested is maybe just the format and structure of having several papers is a way of which there can be just a progress report, so there can be one version of an improvement plan and then something separate around progress. The final thing to say is that we have agreed to do a repeat of a kind of mini version of the conference that we held back in November, I think it was last year, for the frontline staff, which will be a morning, and a workshop in the afternoon to be held in June, which will also include a clinical visit. And we've been looking at sharing an assurance framework with the health board around how we will assess assurance leading up to the autumn period. So that's a bit of a whistle-stop tour. I'm happy to take any questions.
Thank you, Denise. That's really helpful. Can I just ask one thing before I open it up? You talk about the improvement plan being an iterative plan, really. So the board has approved it in principle, subject to the views from the oversight panel. Do you think we should move then to approve it as final and then the progress reports against it? How would you advise us to proceed from here?
Well, I think there's just some small areas I think could just be finessed in the improvement plan to enable the oversight panel to kind of give a final approval to the plan at ahead of your next board. But I think separately, because it's always going to be changing. I mean, we've seen the All Wales report will impact on that. I think separately having a progress report, so that there's not a separate report that's looking at what's happened so far. I think having a separate paper, which is the progress against the plan, is one way forward. And then that would mean that the improvement plan itself should more or less be the same. There may be some updates to be done. But what we don't want to do is spend a lot of time in the administration of this, but really focusing on the progress and improvement part.
Thank you, Denise. Liz, please come in.
So firstly, thanks as ever to Denise and the whole of the oversight panel. Knowing that they're there and that we can just check things out with them is extremely supportive and really, really helpful. As Denise said, myself and Fiona, our programme lead, met with Denise and Anne, and we went through this. I think the structure of the improvement programme and the way that it's set out will be fixed. But every time we report, there will be progress. So we're just thinking about how we can fix that framework, if you like, but then have the progress reports against it. We do provide highlight reports into the exec team every month. We do provide some update into QSC, and that'll become more. So Fiona and I, how do we do that? Because the progress will change, but the framework of the plan, you know, the areas we're looking at, particularly the 4 areas, is not going to change, I don't think.
So we could look to try and take the plan and approve it in final form in the plan in the May board.
Yeah.
Subject to you and your oversight colleague, panel colleague having a look at that, Denise. So that the plan then is approved and it's then that matter of progress. Is that okay?
Yeah, I think we could bring the plan back as is in May and get that approval, but we might want to bring the first progress report as well, so that you can see them alongside.
Yeah.
And then in November, bring a 6-month update, yeah, just to see how it sits.
Thank you, Denise. So I'll open it up more broadly for any questions for Denise. Jean, please come in.
Just an observation and a question, if I may. The observation is it's good to see the intention of the strength and focus on the experiences of partners and fathers, because we often forget about the fathers. And I think the opportunity to further develop the family engagement theme, that's really useful moving forward. And my question is a granular question, but it's relation to the risk assessment relating to the full implementation of the computerized cardiotachograph, which was expected to be resolved last month. Has that happened?
So the system is in and we are utilising it. Matt, there haven't been any issues raised over the last few weeks, but we can go away and check.
I'll check, nothing raised to me.
Yeah, we could check that risk assessment, but thank you.
Yeah, thank you, Jean. Any other questions for Denise? No, Denise, did I hear you say that you thought the oversight panel would step down in the autumn? Don't hear you say that.
Yes, that's the plan. I think you had commissioned us until September, October time. And I think it's really important to say that we are really very positive about structures that the Health Board set up, particularly with the programme board. And I think that gives us confidence that we can, subject to our kind of assurance framework, which we shared with Liz, and our visit, I think we would be able to step back now and be confident that the programme board will continue, because the whole of the improvement plan will not be complete, I would expect, by September, October time, but there has been a huge amount of progress, and I think that progress will need to continue.
Yes, thank you, Judith. And of course, that is of real interest to us as well, given our level 4 escalation status and what we need to have in place to look for de-escalation, really. So that's really helpful to know that. So if we've no other questions or comments, Denise, it's always a pleasure to see you and to hear from you and the panel. And we send you and the panel our deep appreciation for all the ongoing support you give us in such a constructive, helpful way, because we are on a continuous improvement journey. We know that you're alongside us, you scrutinise us rigorously, but you do it in a very helpful, constructive way, for which we're really grateful. And we look forward to seeing you. We think it's the 18th of June. 18th of June. We look forward to seeing you on the 18th of June for the next event. Okay.
Well, thank you very much, and thank you for everyone's hard work as well. Thank you very much.
Thank you very much. So that is really very good. Well done, Jean and the team, for all the progress that you've been making there. So again, going back in reverse order, we'll take Perinatal Committee next. Liz,
Thanks, Chair. I just want to start really by setting the context of this, and the report starts with this. You know, every woman, every baby, every family deserves safe, high quality and compassionate care. And most people tell us they have that within our maternity and neonatal services. But we know that sometimes we don't get it right and care falls short. And the impact of that is profound for those families. So in the context of reporting the facts, the figures, the benchmarks, I just want to say that we are committed to listening, learning and improving so that every family receives the care and respect they deserve in our services. And Anne-Louise was with me at Perinatal Committee this week, and the passion in that team to get this right is evident, and I don't think we would have made the progress if we hadn't had that passion in the team. So from a perinatal improvement programme, you've just heard where we are, and we'll continue to report progress as we've said. We had 257 births in January and 261 babies are born. So again, we had some multiple births. Like most areas in the UK, as Denise alluded to, there is a gradual rise in the caesarean section rates. And here we have a 43% caesarean section rate, and that is in line with what we've seen across the country. Now, when we look at that, some of that is around choice, and choice is really important for every woman and birthing person. And we also have complex needs in some of our community as well. But it is most definitely driven by choice more than anything else. We've got a specific working group looking at C-section, because what we heard back when we've engaged is that our women and birthing people want to know about, really be fully informed about their births and the mode of birth, that we plan caesarean capacity really well, and that it's coordinated, that theatre scheduling is safe, equitable and efficient, and that does prove challenging for us sometimes. And we've started to trial a new digital booking system which will help to support that. Just want to pull out from an infection rate is one of the things that we measure after caesarean section, and we've seen recent improvements in our infection rate. We've been providing training for community midwives on wound care and working more closely with GPs to recognise that early detection of any kind of infection. And we're now working with our Black ethnic minority community to look at what does an infection look like, particularly with their skin, and that's a real piece of work that we're finding beneficial for us and for our learning, but also within that community. Perinatal mortality, morbidity and HIE. We know that every baby lost is a tragedy whenever that happens through pregnancy, and we follow the national processes through Embrace. But I think we all know that acronym now, but I will go through it if nobody does, which provides independent review to support learning both locally and nationally. We've had no stillbirths in January. The finalised 24 national benchmarking shows our stillbirth rate and our neonatal death rates in line with other health boards and other organisations of our size. Every case undergoes a detailed review, and we now provide clear opportunities for families to share questions and be involved in the process. A thematic review of 2025 cases has helped us to strengthen around growth surveillance, and we were hearing in the Perinatal Committee this week around follow-up for non-attendance. So we thought that was a theme in some of our stillbirths in 2025, that women weren't coming to their appointments, and we followed up in a particular way via text, etc. We now have actually changed our process. If you don't turn up once, we write you. If you don't turn up twice, we come and visit you. So there's a much more strengthened process. The HIE instances, that's where a baby experiences reduced oxygen around the time of birth. It's rare, but obviously can be really, really serious. Our rolling 12 months moderate severe HIE rate has fallen, from 3.32 in 2024 to 1.24 per thousand births now. We think that the CTG monitoring and the electronic monitoring has helped that hugely, so the fetal monitoring data. Maternity triage, I'm really pleased to say that in March our one number line went live, and we're monitoring how many women come through that now. But in January we saw over 500 women through triage, 93% were triaged within 15 minutes. We have had some challenges around the follow-up then from our medical, the doctors that are medically covering that area, but there have been no adverse incidents reported in any of those delays. We also report on perinatal tears and postpartum hemorrhage, and we are in national benchmarks around that as well, and we've made some significant improvements, specifically around postpartum hemorrhage. You heard Denise mention ITU admissions. We do monitor those. The two-site working that she was alluding to, we've now got very clear processes daily to review any pregnant woman that is outside of the maternity unit. And she also alluded to a birth in ED last month, which was very well managed by all, with direct cover from our obstetricians and midwives. Incident complaints and learning, we've made substantial improvements in closing incidents and closing down our complaints. Numbers are now quite low in waiting to be closed. Those that we are specifically waiting for tend to have had an external review when we're waiting for that to finish. Duty of candour, we are recording and is being implemented well. We've got a huge reduction in the backlog of concerns. We were just reflecting on that this week in perinatal committee. Experience and engagement. As Denise said, listening is so important. We've learned so much already from that listening, albeit it wasn't in the best of circumstances at the beginning. And from that listening, our communities have told us around waiting times, especially in antenatal clinics. So we're now redesigning that pathway. Denise is right. We had some complaints specifically around our postnatal wards. And then when we realised the pressure on our postnatal wards has changed because of the caesarean section rate and the care that's required. So we're remodelling the staffing there and what support we can put in as well. Our experienced midwife, patient experienced midwife, has made a significant difference in getting into communities that we were finding really hard to reach. She is doing a specific piece of work for us now, leading it across the service around the recognition of fathers and partners' experiences, including dedicated resources and involvement in education. And we know that's something that's come out of the All Wales review as well. Workforce, there's been some challenges around neonatal medical staffing, but that team have pulled together and covered it, and there's been no detriment to service. And mandatory training compliance is good, and you can see from the report, we know what, if anywhere, any area is dropping down, and if it does, we have targeted intervention there. Neonatal and peri-prem data, so the neonatal audit and the peri-prem data is on a national level, and our optimisation scores remain excellent, and some of our clinicians have been leading that across Wales. Yeah, I think that's really all I wanted to highlight. And, we have no negative outliers with national comparators currently, but the constant scrutiny and oversight of that is something that we've now set up in our governance processes, which are daily processes that feed into weekly, monthly reviews, and then perinatal committee. I think our improvement programme, as we've heard, is progressing well. And we really welcome the clear oversight that we have through QSC and into board.
That's brilliant. That is a comprehensive update, and it is so pleasing to hear and listen to all the progress that we're making. So, comments, questions for this? Rena?
Yeah, I just wanted, it's not in the report, I don't think, but I was wondering how the birthing centre is embedding and how many of the births that are recorded in the report and what percentage, perhaps not so detailed figures, are actually taking place in the birthing centre as opposed to Singleton?
So we know that in the first year of the birthing centre being open, we had 197 births, and we had 197 births in the birthing centre, and they supported around 75 home births from that community team. In the second year of that being open, so from September to now, we've had 85 births in that birthing centre with 85 births with 35 home births. So,
I think Abby's got some more details there. Really, you must have been reading my mind. So the benefit of having all the dashboards, I was thinking exactly the same thing. So I did open the dashboard to see how much we've got going through. And I do wonder whether we might ask for a look at that, because clearly it's great to have that access and availability. But I guess wanting assurance around keeping up skills, because I pulled out the data on a weekly basis, and majority of the weeks it's single digit numbers of births in the birthing centre, and that's we in fact every
about 14 a month, I think.
So it's they are. So I'm looking at the births in the midwifery led unit at Singleton, but the births in the birthing centre are definitely in single numbers and quite often in the 1s and 2s. So there's definitely something about asking for oversight about how staff get their skills up, et cetera, et cetera. So maybe we could look at that, because it's never got to the level that, as I understand it, we set when the board approved the reopening.
We are
50 this, I think.
It's more like 300 to be viable. We had a report, if you remember, when we've been open for 6 months and then a year. I was waiting because we were going to do that on a 6-monthly basis. Unfortunately, our consultant midwife hasn't been here. She's been off, but I have specifically asked for a report on the birthing centre to come through perinatal committee to QSC as soon as we can.
Thank you, Rena. That is an important point that you raised there. Thank you. Matt, then Teresa.
Can I just quickly come back at the cardio, I can say it right, cardio issue that Jean raised. No issues for a while, for a long while now. It was Wi-Fi blipping out, no issues, but there is a workaround now. If that happens, there's a business continuity plan, so no issues.
That's helpful. Teresa, please come in.
Thank you. My question was mainly around C-sections. And I was curious to know if we understood some of the underlying causes that are driving the choice for women to opt or birth and people to opt in for cesarean sections. And do we know what demographics are most likely to opt in or opt out? Do we understand that data by demographics?
So we would be able to look at the data and have the demographics around it. But when you consider 43%, so in some areas of the country, caesarean section has now overtaken vaginal mode of delivery. So there's a lot of work going on nationally. It is significantly around choice, but we can certainly pull out the demographics and we'll have that information.
Thank you. And we'll do that, Teresa. And Liz will liaise with you outside the meeting. So did you want to add to that point?
We know that we've got a large number of our population who are overweight, and that does add to the risk factors, obviously, not just for the mother but also the baby. So we are very keen that we understand this, but the dashboard is just to alert that the dashboard weight management information at the moment is just undergoing review to ensure that it's accurate. But we should be able to look at that as a risk factor, and then obviously everything that comes from that. So diabetes and pregnancy, high chemical pregnancy, preeclampsia, and all those other risks, because obviously there is an element. Yeah, there's also an element of possibly it's not like another.
I suppose that's what I was alluding to, Teresa, when I said a lot of it is choice, but it's also the complexity of the population that we care for as well. So we have all of that information.
So we'll give you a briefing outside the meeting, Teresa. Okay, Jean, please come in.
Two things. I just wanted to put on record my thanks to both Raj and Liz for the work that they've done in bringing all of this into quality and safety, because the way in which we analyse the information now is far different to the statistical information we used to get. So thank you both for that from the perspective of both quality and safety of our patient and their families. My next question is probably something that you'd say, can you take that offline? But just reflecting on Denise Schaefer's comment about families, etc., and the work that we do, and the fact that you're running the Women's Experience Forums every month. I wondered whether there was something we could do about learning from the themes that are coming out of that, so that we had greater transparency of those.
Definitely we can. We discussed them in detail at perinatal committee. So yeah, we can expand on that in a report to come to QSD.
Yeah, I think that would be useful.
Even if it was kind of in a kind of quarterly basis, because we hold the events and then we look at what the families attend us and then we make changes.
And it would be good to engage ICE in that as well.
Yes.
Yes. Patient voice. Yeah.
Yes.
Okay. Thank you.
I have contacted Liz.
Thank you. So we'll bring this to a conclusion now. So Liz, you're asking the board to take advice on a number of things, to be alerted and then to be assured. So can we accept everything that we're asked to do in the report that Liz has set out? We obviously agreed to bring back the improvement plan to the May board, and hopefully we can sign that off and then move into progress reports thereafter. We'll do some more specific work around the birthing unit in Portugal, as we agreed, and then we will be looking at the whole the strategic approach to family and community engagement. And as I think you're also thinking of a companion piece, what is essentially a professional technical report.
Yeah.
For families and communities to go alongside this.
Definitely. And we've because I mean this is published obviously because this is our public board, but we discussed at perinatal committee this week that process of should we have a companion report and what should that look like. So we've committed to engage with our women and families group to ask them what would they like to see. So to share the information and talk to them about how they think it could be best interpreted for that group.
Thank you. So Jean, we'll come to QSD AAA report then, please.
Well, we'll reiterate what's in the report, and we have already mentioned some of the matters. I think the alert that we've given on your next patient in terms of the risk profile, Liz and her counterpart will do some more work on that. We're having a deep dive coming into the next committee meeting in April on clinically optimized patients, because one of the concerns is we are utilising beds now in an inappropriate manner. We're having new patients going in at the front end, as well as not managing those that should be coming out at the back end. So there's a whole deep dive for us to understand how we're going to manage clinically optimized patients through 26, 27. That's a huge piece of work. We also are ensuring that mental health and perinatal are still coming to every committee meeting. And there are a number of things that we need to discuss in terms of giving transparency to internal and specifically external inspection reports, because we need to ensure that we are delivering recommendations from any review in a timely manner. And it's pleasing to see that a lot of the actions that we had outstanding have been dealt with now, but we will continue to focus on that as we move forward.
Thank you. Thank you, Jean. And we're happy to receive the AAA report from QSB and take assurance as Jean has outlined. So we'll take the mental health report now, and then we'll have a 10-minute cuppa after that before we press on to the end. So happy over to you.
Yeah, thank you very much. This really builds on the overview I gave as part of my chief exec report. which talked about the 5 work streams that we've got sitting under the Mental Health Transformation Board. So the work on the service model, quality and safety, the workforce issues, the digital enablement, and most in a cause of concern, I guess, is around the estates. So the estates work stream is doing an awful lot of work. If you recall, prior to Christmas, the board received a comprehensive report from Marin's Swansea University building around our plan for short, medium and long-term action to address the real concerns we've got, particularly around the acute inpatient environment in Kevin Coyd. We talked about the urgent work that we would be undertaking, and just to give you an update on the urgent work, that work was scoped and put out to tender and has commenced in the way that we've described. One of the challenges is doing it round patients, so they're having to close a bed down at a time to do the bed refurbishment. But I know that there's really positive feedback from the service group and from patients about the improvements we've seen. So things like laundry, I can tell you they've got proper washing machines in the laundry now, as opposed to ones that don't really survive the amount of use that they are used. So that work is progressing. The second decision the board took prior to Christmas was around an interim solution. As you recall, we looked at a number of different options, and we had a preferred option, which was not an easy option in terms of deliverability and cost. But based on the recommendation from Mel and the working group on the state, was the best option available to us in terms of addressing the concerns. And you'll recall that was an option to consolidate the older people's wards at Newport Talbot and enable us to use the current environment in the older people's wards at Kevin Coyd for the adult wards, and develop one place for our inpatient adult wards for acute care. The action, the longer term option was then working through what is the right model in terms of proper planning through thinking about how the world has moved on from the previous outline case that was developed around things like interdependencies, service alignment that we might want to reflect, and the fact that our financial outlook is very, very different. And that comes back to the conversation, Steve, we were having earlier about consolidation on smaller sites. Definitely doesn't cost as much if you've got staff consolidated on fewer sites. So you haven't got security costs on multiple sites, for example. The action that we endorsed as a board was to engage following the government conversations around our short urgent actions, our interim and our longer term, and myself and Deb and Marie, and it was Darren and now Claire will join those conversations along with Dermot in the team, and our capital colleagues, both Simon and Ian, have had 3 meetings with both Welsh Government officials, policy and performance, and the capital side, and NHS performance and improvement. And the upshot of those conversations is recognition that we are in a difficult position, recognition around the risk that we are holding as an organisation in relation to the poor quality of the environment. We have invited and will follow up invitations to come and visit, because I think there's nothing like seeing it. And for those of you who've been recently, and it really brings it to life just how difficult it is for patients to be receiving their acute care, and it's difficult for staff, as we heard in the last board development session. There was not support for the interim solution for 2 reasons. One, would it stand the test of good investment of public funding when capital is very, very stretched? If you recall, it was a circa 35 million investment that we required, and it still doesn't get us to where we would want to be. There would still be compromises in terms of the model of care. So we would still want to be pushing ahead with the permanent long-term solution. So government or the feedback we had was that was not the supportable interim option. I think the second reason why was we are not the only health board that's looking for capital investment into mental health services, and there are some other health boards that have got challenges. And the reason that performance and improvement came to the meeting is that's clearly where the national strategy and driving delivery of the national strategy is sitting under the National Mental Health Programme. And Welsh Government wanted to take stock and look at, is there a regional solution for health boards working together in terms of resolving the acute inpatient bed issue, recognising that we are probably high up there in terms of level of risk and demand, but needing to work it through on that basis. That work is in its infancy. It is coming to the leadership board in May, an update in terms of what that work is. But clearly we don't have very much detail at all, other than Welsh Government indicating that the reason the second reason that they didn't support our interim is that they want to see a permanent solution much quicker. So the conversation was about, could we deliver that in 4 years? That's what we should all be focused on. That is a big challenge to deliver that when we don't know what the permanent solution would be. Welsh Government asked us to pull together a bold plan for stabilisation of our existing services. So you will be aware that not only is the work that the team are doing now, but there is the continuation of the ligature risk assessment. There's the Section 136 suite not being fit for purpose. And there is the service issues in terms of the risk of failure in terms of the way that the services come into Kevin Coyd main block in terms of inpatients. So we were asked to do work on what it would take to stabilise the site at Kevin Coyd and the services. The estates and capital team have done that. They've worked really hard, and it seems like we keep asking them to do another thing. But they presented that, which is not fully costed or tendered, so it's their best guesstimate with their knowledge around what needs to be done. And that would be circa 20 million to do that work. So it's substantially less than the interim solution. And it would stabilise, but it doesn't actually fundamentally address the service challenges that we've got in terms of things like there being not adequate space for therapeutic intervention. There aren't spaces for families. We know the outside space is not conducive to recovery and having a pleasant space in which therapeutic intervention can take place. So we find ourselves in a position where we are cracking on with the short-term work. The team are working up the stabilisation plan, and government are very open to recognising that we're going to need to do that work and to do that quickly. So there is follow-up conversation about how we would get line of sight to that. And then we leave ourselves, I think, in a position where we're holding the risk still on the lack of configuration. And if you think about our concern of Ward F sitting on us as isolated ward, not co-located with the other adult wards, and that means that we are continuing to manage and need to address that risk. So there will be cost implications, workforce implications, because we are not delivering optimal care in terms of configuration, and it's very poor environment anyway in terms of therapeutic intervention. So I know that will be a difficult position for the board to accept. In the Transformation Board meeting yesterday, we talked through all 3 work streams. So we talked through the work that's ongoing and being delivered now, and you have the update on where we are in the timescale and the phasing of that work. So it's in our capital plan. The timescale is dictated by how quickly they can get it into those clinical areas and deliver the programme. So it's not as quick as we would like because of that. The stabilisation work will include all the urgent works that we've talked about and how you would phase that. So the further work around Section 136, the services work I described, and the rest of the ligature risk assessment work, recognising that operating in a PFI, doing anything in a PFI building, particularly when you're running into a contract, is more problematic and difficult in terms of negotiating that. We did agree that we would continue to flush out what would be our preferred long-term option, recognising that would have to be tested in whatever national or regional conversation anyway. We talked about how we think about the interdependencies, the adjacencies, how we would include recognition that having mother and baby unit where it is not co-located with either paediatrics or obstetrics is not what we would want longer term. It does align with clinical services plan that the headlines will help us with this. But the agreement we took in the transformation board, and I hope perhaps the board will support us, is to carry on working that detail up and testing that. We have asked through conversation with Melanie, our special advisor or expert advisor, are there any other options in terms of the position we're in? And I think there are a couple of things that we can explore. Because as you will be aware at the moment, because we've reduced demand on older person services, we do have a ward that's not being utilised. We wouldn't expect to see that overall being utilised because we know that we've got more beds per head of population than you would expect to see for older people in your what's really assessment rather than ongoing treatment environment, and whether that gives us different options in this stabilisation phase. So I'm afraid I'm not bringing any better news in terms of a green light to progress, and it does leave us in a sort of a state of limbo while we're waiting for whatever the a sort of blueprint at a regional level might look like. We have had informal conversation with neighbouring health boards. It's not high up on the agenda for Haldar. Certainly, they've already got a sort of a co-located or aligned model with their DGHs, which is what we've been talking around our services. And indeed, CTM is looking at their own provision and how they might develop their services. And obviously, we've got shared agenda because we're delivering low secure, medium secure out of estate, which is CTM estate, which we know does create some challenges in terms of the process. So that's the position we're in. As I said, the action that we agreed in Transformation Board, obviously crack on, and we're keeping weekly oversight of the improvement that's happening now to make sure it remains on track. And there's really good dialogue between estates and the service group, and making sure we keep on top of new things that come up, because we know this is a estate that is heavily used, and wanting it to feel, I mean, we know that when you drive up and when you see derelict site is your first impression when you arrive on the site. It doesn't have a feel about it. So the stabilisation work that we described could include an option to look at how we would deal with the kind of derelict bit of the site as well, and address some of the concerns and issues that we have there. So continuing with that work, putting in the detail around the stabilisation so we could get that into Welsh Government as quickly as we possibly can. And I think in light of the risks, we have to do that anyway at this point. And as I said, continue to flesh out with the principles and the clinical services plan, our own principles that we agreed when the original engagement was undertaken, how many years ago now, Richard, which still...
I think 21, yeah.
Yeah, so using some of that, I think updated with Melanie's and other guidance around things like co-location and where you'd get patient benefit from co-locating, that we would flesh out what we think that would be as we had previously intended.
Thank you. Before I open it up, Welsh Government published their mental health strategy last year, but unless I missed it, and perhaps Marie, you can tell me, I'm not aware that it included a regional approach for adult acute mental health services.
It didn't, no.
And I don't think that's excellent Welsh Government policy. So I just want people to know that, because we've had nothing to indicate that it actually is. So that is an important point of principle for me. And also, I just want you to know that, as you do know, members of the board, in every single review meeting I've had this year with the Cabinet Secretary, I have said that the level of risk we are tolerating in Cefn Coed is unacceptable and unsustainable, and we really should not go on carrying this level of risk, and certainly not as sole owners of this level of risk. I just need you to know that before I open it. Marie.
So I think that the new head of P&I has recognised from the discussions he's had with others, Agnes in particular, that this is a significant and unacceptable risk, and he is bringing back a proposal around how leadership or Wales leadership needs to respond from a kind of mental health improvement perspective, including infrastructure as part of that proposed approach. So I think there's going to be a discussion next month at the NHS Leadership Board as to how that could be accelerated and rolled out. So I do think it is being taken seriously at national level.
Thank you. And the other thing following on from the last meeting, which I actually think is helpful, and I held off doing this until we had the Transformation Board yesterday and the board meeting today, is that there is an ask back from Chris Clayton, who chairs, who's been chairing meetings and been helpful in terms of guiding us through the conversations, to put a position statement back from our organisation, actually done jointly with the national lead, Kira Rogers, which I think will be really helpful. So on the back of the conversation today and the transformation board, I will work. I've asked Dermot and Simon Davis to start drafting that, and we'll sign that off as a group and share that with the board as well.
Thank you, Abby. Jean, please come in, and Steve. Yeah, thank you, Abby, for that comprehensive update. Unfortunately, it does nothing to alleviate the horror that I experienced when I visited Kevin Coyd. I actually took the opportunity to look up the definition of trauma-informed care. Everybody talking about mental health has mentioned trauma-informed care. And it said it provides comprehensive, person-centered approach that recognises pervasive impact of trauma on individual lives. And I have to say that when I walked away from Kevin Coyd, I thought that we were having not pervasive, but direct negative impact on the service that we were able to give to our patients and the situation that we were expecting our staff to work in day to day. And I don't wish that to sound sensationalized. It was a true feeling when I walked away that I had to question, and I did write to both you and Jan, I had to question whether I, as an independent member, could continue to accept the risk that Welsh Government were asking me and the board, per se, to accept. And I don't believe we can, because not only is there the question of that inadequacy of service and environment, notwithstanding the state of the estate, but there's also the question about, are we spending public money in the right way? We now have to go away. You've just talked about 20 million to stabilise. We've talked about 5, 6, 7 million that we're now using to apply cosmetic painting and some refurb to some of the rooms that those patients are in. But frankly, I've worked in prisons, and to see some of that environment just took me back. The external areas, the opportunity for people to even hang their clothes up, because we can't provide safety hanging. Clothes are on the floor. Yes, they've got units that they can fold their clothes up and put in, but some of them are not big enough to accept heavy coats. People can't go out because there are no outside facilities if it's raining. So those who smoke were coming in and stubbing out the cigarettes on the windowsills. I just walked away and thought I had to bring up, as an IM member, to the board today, the fact that I am not prepared to accept the risk any longer that Welsh Government are imposing upon us. And I would like to address that to the board.
I've got Steve, then Nuria, then Rena.
And our predecessors in this room in 2016, I believe they said to Welsh Government, we can't continue with this building is in its last 5 years. And now Welsh Government or I are saying, hold on for another 5 years. So that'll be 15 years since we already said this was a burning plan, which is, Jean's absolutely right. It's not acceptable. And you were there during the day, I assume. If you go there during the night.
Oh, I was there during the night.
You were in the night. So that's when the vermin come down. But about this 19-20 million, if there's any chance of getting it, like in Marie's plan, we've got 5 million for ligature risks, 8 million for painting that Jean referred to, securing the utilities, etc. Kevin Coyd, and 7 million for demolition. Now it needs demolishing, but if we get 7 million, is that the best way of spending? If we only get 7 million, demolishing with
That
demolishing.
wouldn't be the priority, no, Steve, you're absolutely right.
Yeah.
That is, if you've got contractors and you're doing work, it would reduce the risk that we know we're carrying by having a derelict building. But we wouldn't choose that as the priority over the other things. I think the issue is how much we are actually able to do when it's a living, breathing care environment, and that really restricts the amount of work that we could do. So I know the estates team have worked very closely, and I do think that's one of the outcomes of this, is that there is very good working between the estates team and the service group to make sure it's planned properly, and actually the contractors who are doing the work at the moment. So that has to be factored in terms of what can be delivered. And I think irrespective, we are in the position where we need that work to be completed for the reason that you just described, Steve, the service risk that we talked about before needing to be addressed.
It's a very similar point to Steve, actually, which is about, we talk about risk and we need to understand what we mean. And I think we've been going in circles with this for so long. It's been in our board conversations. We've raised it again and again and again. I think we need to be very clear in relation to the money that we've got, is what is it that we're actually tolerating in terms of the risk, and where is our appetite as a board, which goes back to Jean's point. And I think we need a board decision on this in terms of the next steps, because that 7 million is to do something that perhaps is not where we want to go in terms of the direction of travel, and our biggest strategic approach is cosmetic. Yeah, it's cosmetic.
So I think the separating out the capital and the revenue. So there's something about different pots. One of the things that we will need to look at is that the work on workforce. So I think the teams do an incredible job. And when HIW visited, whenever it is they last visited, which was not that long ago, they did talk about, despite the challenging environments, staff doing a really good job providing therapeutic care. And I know, Jean, your feedback was that you talked to a lot of staff and a lot of patients. So we're asking them, and we had the conversation with some of them, didn't we, in the board development session, which I think they really welcomed. So I think there's one of the things, I think you're asking a really important question about risk. So what is the risk around the physical environment, and how can we do everything we can to mitigate? There's sort of a risk in the environment, and then there's not being fit for purpose and providing the right kind of therapeutic environment. So I think we can describe that, and I think Mel's report described that, original report described that really well. When we do the board development session, and I'll bring a more comprehensive update on all of the aspects of the transformation programme, if it's helpful to the next board meeting, and get the cycle of that right. We agreed yesterday in the transformation board to look at how we prioritise what they've identified as in staffing gaps. So we know that the service group has been utilising a higher than we would like non-core variable paid to shore up staffing. And I think we've heard examples of where we've ensured that the right staffing is available on every shift to keep patients safe. But what the work has identified is that our core staffing is not where it needs to be, particularly in relation to nursing and healthcare support worker. So as part of our process, because we're spending the money through variable pay, but needing to get those establishment right, and Liz's team have done a lot of work, we need to prioritise that and work through, and that's what we agreed in the transformation board. So we need to apply good governance, because you'll have all read the Deloitte's work about sometimes we put money in, which is permanent investment, without really being clear. So what risks is it addressing? So what we've asked for is not War and Peace in a business case, but to set that out. So if we were to come back in an investment light year, definitely, that we wanted to increase the substantial staffing or the core staffing, the establishments, what risks we'll be addressing as part of that. So that work is going to happen quickly, and we won't have a long drawn out process. We'll take it through the business case process just so that we've got line of sight to that, and we can ask those questions around if we are going to invest. I can't remember what it was now in terms of the number of posts, and we've got a cohort coming out for training in September, I think it is. So it's quite good timing in terms of training places coming out of uni. That we're able to establish those posts and go through recruitment, but we've got the governance around it, around what risk is that mitigating and to establish. So
I think that would really welcome that, and that's the next steps, and understanding what are we actually tolerating, so that we can have the discussion around what's an appetite, where are we now.
Thank you.
Helpful. Rena?
Yeah, I just go back to Jean's point, really. I do feel we've known about this risk for a long time with the health. And frankly, we haven't moved it on, not through our own not wanting to. And I know we've done a lot of work over the last couple of years, but I still feel we're in the same position. We've not gone forward. And I don't think we are going forward at the moment because we can't, if you like, get recognition from Welsh Government as to the level of investment required here to actually reform what we want. And in a way, I think that is the key issue. So I do think we need to go back to Welsh Government and escalate this in terms of they need to share the understanding of the risk, because it's not just our risk, it's part of NHS Wales risk. Because if those buildings failed, say tomorrow we had, I don't know, a fire or whatever, there would have to be a requirement on other health boards to help us out, wouldn't there? It's NHS Wales. So the reality being, it is a shared risk, but I think we need to be very firm with the Welsh Government on them accepting that situation. And the other thing is, I do feel I'm still not happy in my mind that we have a sustainable approach in terms of the way we go forward in the medium term. And as Abby said, that's still out for discussion, isn't it, Abby? But the reality being, I wasn't very happy, I will be honest, and I did say it to the board at the time, when we had the idea of what we were going to do in the medium term. I didn't think it was the best plan. But given we've got quite a lot of land at Cefn Coed, we've got a lot of land at Tonna, you know, there's possibilities for us. And I just think we need to be very focused on what is the best solution here, because I think there's only one hit in getting this.
Two comments, if I may. So I do think Welsh Government understand the risk that we are accepting, the risk that we are having to tolerate. I think their issue, and it's not necessarily about not understanding that we need to invest. I think it's from their position, it's trying to make sure that they're able to make reach the best solution in terms of addressing all of the risks that they've got to address or that they're happening across Wales. So I think that has been the tenor of the conversation. It's not been we don't understand the kind of level of risk you're talking about. So just be clear on that. I think the second issue, quite rightly, Welsh Government challenged about our clinical model, because I think we have acknowledged that we have not got the clinical model. That's what the national strategy talks about, and we need to be really clear what our whole patient pathway is, what the stepped model is. We know that we've got too many patients being admitted into inpatient units and into units that are all over the country when we haven't got the alternatives to admission. So the Transformation Board Service Group, which is chaired by the medical director in the service group, is doing a great job, has got the kind of planned care, as we were describing before, and the urgent emergency care. To look at how do you respond in a crisis, and there are models that are much more advanced than ours, which have got support in the community crisis houses that prevent the number of admissions that we have. We're looking at some of the examples. There are not many health boards that are meeting all of those standards now. In fact, probably none of them. But we've been looking at some of the examples in England and touching base with Tees up in the northeast, because they've got a really good model of care. And what we need to do is finish our work on the service model so we can describe very clearly what it is we would want from our inpatient provision. We can benchmark beds, so we know we will need beds. And broadly speaking, we know what the benchmarking for our population, if you look at deprivation, would look like. What we need to be really clear is we're describing that in the context of the model, and that work is progressing really well, and that will help us, I think, Jean, with your question about what are the codependencies, what is the model we really want, and then we can confirm that we're confident sort of bed numbers that we have been talking about are right size for our population, and that work needs to continue and would need to continue whichever permanent solution we were going to reach.
Jean, do you want to come back first, then Steve?
I don't wish to sound disrespectful. I understand everything that's been said. But my key point here is we put forward a a solution, short, medium, long term. That's been dismissed. And we've now been forced to go back and revisit. My question to the board is, are we prepared to tolerate yet again the risk that Welsh Government officials' decisions have put back to us as a board, notwithstanding our statutory obligations? So that's my ask.
We'll come on to that. Steve?
So to on what Abby was saying, the service model redesign is very important because as of Monday, you'll know because you've got dashboards. We got 25 inappropriate out of area placements. That's not, and that's going into the new year. We'll have 25, I assume, because it's next week. It's costing us about £1 million a month, which is not in the deficit that has been planned. So this is already a pressure on next year. And well, I'm sure that one of the reasons our variable pay in mental health is so high is that it's not a great place to recruit or to retain. Is it? If you go for a job interview at Kevin Coyle or whatever, it's not. And they're more or less being told now you've got another 5 years of this, so it's tough.
And I think that is the conversation with the staff group, I think, is really important because we've engaged them a lot in temporary interim solution, and we'll need to go back and have the conversation with them about the route map through this. Absolutely.
Martin?
Yeah, thank you very much, Chair. Completely agree with the comments that made Jean, completely agree with your comments. I don't know whether it's the right place to bring it up, but within the division, there's a learning disability service here as well that is struggling from the state's perspective. And we continue again to house people, to care for people in substandard accommodation. Now, I know that service has been reviewed and there's an always discussion about LD services. If you look at how we accommodate the very most vulnerable of people within society, within Swansea Bay footprint, it's alarming to say that we continue to support that ethos of behind closed doors. We just ignore the subject of the people who are vulnerable, who have a learning disability, fail to have accommodation which is conducive to their rehabilitation, I suppose, into a better accommodation, maybe in social care, for example. And I think the footprint that we've got and the services that we've got don't help really within LD services as well. And I think it's appalling that we see, and I work within the service personally, that we allow accommodation, admissions of patients into areas which are substandard. I mean, Cardiff is a classic example where Park Place, I hear, and I read the other day, is going to be rebuilt. Next door to that building site is an assessment unit, which is highly substandard to accommodate the most vulnerable of people at the time of admission, really. And I think it's something that we need to consider. It's another headache, unfortunately, for the board and for you, Chief Exec. I think that needs to be taken up as well.
Thank you, Martin. And we did say earlier, didn't we, that the transformation programme will look at disability. Any final comments? So just try and summarise where we are then. So the interim solution we came up with in November was not ideal. And, you know, as you said, Raina, you were vocal at the time that you didn't support it and you wanted us to look at the mountable option, if you remember, because you just weren't happy. So it wasn't ideal. We know that we haven't progressed the clinical model in the way that we need to. We've got far too much focus on acute inpatient facilities. And let's be quite clear, we have not given this the attention and the focus as a board that we should have done. And it is of some distress to me that 22 months after I take up my role, and you know, in the autumn of 24, I made it quite clear that I thought that the position was unacceptable and unsustainable. and 22 months we are still here. So I really think as a board, we're going to have to look at the bandwidth we're giving mental health services as we go forward. So talk about the risks and the risks we are tolerating. There are risks around the physical environment. And when we took the urgent decision on the interim position, we were told that we faced a potential catastrophic infrastructure failure at any point of the services in Cefn Coed, and that we had no business continuity model, we had no backup. So that could change in that sense. So it's the risk around the physical environment. It's the risk around the fact that these facilities are not fit for 21st century modern mental health care. What isn't in question at the minute is the quality of the care that staff are working day in, day out to deliver in very compromised environments. So we are clinically compromised because of the environment, but HIW has indicated that the quality of the care, staff go the extra mile. Now, Welsh Government will say that the safety of services and facilities is a matter for the Health Board, and it is a statutory duty. So we have, as I would say, we're woken up to our responsibility as a board, and we did put forward a solution in November that has not attracted support. And I personally do think that we have to challenge the concept of a regional solution. We are the second in the world. We have a 400,000 population who will have requirements for immediate access to acute and crisis care. And a regional model is inappropriate, and no other health board would find themselves in that position. So we cannot go out to the market and borrow capital ourselves. So however unpalatable the choices that Welsh Government are putting to us at the minute, we have to find a way of working with them in partnership. But Jean, I pick up your point. I do not think as a board we can tolerate this risk alone or solely, right? We've looked at our deficit and the principles there apply across the piece. There are those matters for which we are in complete control. They are within our gift to resolve. There are those matters that are strategic. There are those matters that are structural. And the resolution for mental health services in the Swansea Bay, they are both strategic and structural. We can do what we can in respect of staffing levels, ligature risk assessment, etc. We can make things as safe as we can make them. We cannot resolve this situation alone, but nor should we accept this risk alone. So I would suggest that Abby and I write to the Cabinet Secretary and to Jacqueline Totterdell to set out the circumstances in which the board finds itself, but to make it absolutely clear that this is a shared risk and that we are expecting that risk to be shared, and we are expecting the national programme, when it's rolled out and when all the implications are looked at, to pay due care and attention to the second city of Wales with a 400,000 population with a need for access to adult acute services in the same way as every other health board has in Wales. It is incumbent on us, I think, and Abby, it is really important to put this position statement together as quickly as we possibly can, because our clinical model is not where it needs to be. Abby, joking.
Thank you. We will, I think there are a number of different actions. So I think the work that I described, we will continue to progress, because I think we have no alternative, and I think that's the right thing to do. We will get the statement. We did agree, and Dermot and Simon and Ian from our Capital and Estates team are drafting that, and I will oversee that and make sure Welsh Government, who need to contribute to it as well from their perspective, so that there's a statement of the position, which I think is really helpful to us. And Yuri, your point, we will describe the risk in that, so that it's really clear. It's not just about lack of optimal provision, it is about the risk created by the environment. I think it's really helpful, Jan, your final comments about recognising that we need to make sure that we work on our model of care in line with the national strategy and our pathway to be able to deliver it, because we're going to have to develop some of these services that don't exist at the moment. And we will need to have confidence that we know what our journey through that work is. I think when we come to the board development session, we will invite the service group obviously to present where they've got to in that model and how they see with us transitioning to the model of care that's required. And bear in mind, one of the things that we've got to deliver by the 31st of March of the next financial year is an open access model for mental health services. So some of this we will need to have in place irrespective of where we are with the inpatient model. And Jan, we'll draft a letter that goes from you and I to Jacqueline Totterdale on the back of the conversation and the Cabinet Secretary. I did raise it with the Chief Executive yesterday as part of a wider conversation. And there, I appreciate your comments, Jan, about how we create enough space in our agenda to have oversight of this. Just we are with perinatal. There's something else I said earlier about whether we bring through a kind of a report of the same from a quality and safety lens. And I will make sure that we're getting, whether it's quarterly or 6 monthly reports on the transformation board, more formally coming in here as the chair of the board. And the other thing to probably acknowledge is that in our discussions, it's been really helpful having a subject matter expert helping us with this work. That's not a permanent solution. We've extended that arrangement, but we do need to make sure that we've got that level that's sitting above the service group. And we have agreed that we'd have a board level position around that, and we finalised the job description. It's in Welsh Government for the process that they have to go through in terms of evaluation. So as soon as we can get that established, I think that will also help, Jan, in terms of the detailed oversight and keeping it on our agenda. Thank you.
Can we agree then that, you know, we do have some liability for the situation we find ourselves in, and we can't deny that. We do have some liability, but we find ourselves in a position we cannot resolve this alone, and we cannot accept the ongoing risk, the scale of this risk alone. It is a matter of risk sharing with Welsh Government because this solution is strategic, it's structural. We cannot, it is not in our gift to go out and borrow capital to resolve this matter. We want to work in partnership with Welsh Government, but there really needs to be a very clear understanding of where we find ourselves and the mental health services configuration we have that we really need to transform for the people of Swansea Bay and Newport Talbot. And Abby and I will write to the Cabinet Secretary and Jacqueline Totterdale on that basis, whilst we continue to work up position statement, really focus on model that we actually need. And coming back to the points as well, that when we're putting forward the position statements and we're working with Welsh Government colleagues, we look at the way of spending public money that is the optimum investment we can make it in the short term, so that we're not wasting public money and that we're accelerating the time frame as well as we possibly can. It's the second oldest estate in Wales in use for clinical services. There is only St Cadoc's in Aneurin Bevan, 1906, and Kevin Coyle is 1932. So, you know, this is a really, really major priority for Welsh Government. Are we content?
Yes, thank you.
Thank you. So let's have a cuppa and then we'll come back and get to the end of the agenda.
I know. So I know it's like people think they're helping, but it's just can't find it that way.
Yeah.
our agenda. So no, we'll get going again. And we're now on to section 5 and Peter and Rena, AAA report for workforce.
Not much to add, just there are a couple of alerts here on particularly the issue of the staff story, which was quite distressing to hear about the fact that there was a delay in implementing the health board's policy for managing vexatious and high-risk complainants. And that had given rise to some safety concerns amongst staff. So we've referred it to Quality and Safety Committee to have a look at. And the other one was in relation to the ongoing problems with sickness absence within primary, community and therapy. The last thing I would mention, you can see the report there, but I know this is something that everybody's concerned about. The Organised for Success programme is progressing and we are receiving reports at every workforce on it. And I'm also receiving updates from Tina herself on it on a regular basis, but it certainly is moving forward.
Oh, thank you, Rena. Any comments or questions for Rena? Thank you very much.
Sorry,
You can take it.
Chair,
Oh, Steve,
if I may.
have one.
Serena, the sickness absences, which particular area of primary care is there?
It's across the piece, but there is particular concerns amongst the community side.
Okay.
Thank you. We'll take assurance and we'll move now to HIW commissioning. So Carla, yeah, thank you. And then Hazel will go for new team. Thank you very much. So Sharon, are you presenting? Yes. Thank you. Let's make that shot. It's hard to read. Okay, Sharon, you can take it as read. That's okay.
Thank you.
Yeah.
So just in summary, this paper supports the submission of, it's an annual event. We do it every year. But instead of being submitted to Welsh Government, it's submitted to HIW. And it's concerned really with forecasting, explaining our need then to HIW in terms of the number of university places that we require in order to train the workforce of the future. Ordinarily, it doesn't really have any alignment with finance, but I think because of financial challenges, which we know we're in now, and we know that we're going to have for the next few years, it has actually had an impact in terms of the number of places we've commissioned this year. So for instance, I think over the last years, nursing tends to be the biggest number that we commission, and that's been reduced now this year from 350 down by 110. And actually, every profession has reduced their requirements slightly. There's been some reductions in terms of our therapy and therapy professions, and right across the board. The only bit that you may struggle to understand in terms of the paper is pharmacy. Pharmacy looks as though it's gone up, but that's only because of the way that HIW, they changed the format of the spreadsheet this year. So they've added in enhanced and advanced courses into that particular element. In reality, the number of pharmacy places we've asked for has reduced from 86 to 50. So it has to be like the annual plan, it has to be submitted to HIW by the 31st of March. It's gone through the Workers' and OD Committee and was accepted there. So it's just bringing it here for final assurance for application.
Liz, would you like to add?
Yeah, just to be clear, really, we have reduced the ask for places for adult nursing, and they would come out in 4 years' time. And that is not predominantly based on finance. In fact, it's not. It's the fact that we are currently over-established in adult nursing. We know that we want to reset our establishments to get the 21%, not the 26.9. We've worked out how long we think that will take us, and it is going to take us a few years. Our attrition rate currently in our adult areas for registrants is about 2%. So that is the rationale for reducing our registrant workforce. And then with more confidence in a new methodology of workforce planning, you know, we'll see where we are next year, the year after that. But it is predominantly because we are over-established, and it's going to take us some time to rework that.
Any comments or questions for Sharon? So we're happy to approve, Sharon, so we can send these numbers in to HIW by the end of the month. And thanks to everybody who's been involved in compiling this, because it's there are so many uncertainties. And trying to put a set of numbers. That's right, remarkably able to do, really. So thank you very much. Thank you. So we can ask Charlotte to join us, and then we move into part 6. We have a number of AAA reports from our committees, but we'll take them as read. And can I ask committee chairs just to focus on any key matters they want to bring to its attention? Nuria, shall I start with you, please?
We had a really important audit committee in the March meeting. And our focus was very much on strengthening assurance, governance and performance across several critical areas. We looked at the strategic risk report. It highlighted ongoing concerns with consistency and depth of assurance, including aspirational rather than evidence-based scores and controls described in a procedural rather than effectiveness terms. The committee emphasised as a result of that the need for improved scoring consistency, fully updating dates with the appropriate risk register, and evidence that the new escalation routes are fully embedded and understood across service groups. On a positive note, we received a reasonable assurance rating from internal audit in relation to our systems, which was welcomed. We also looked at a long-standing risk relating to Parkway Dental Services and noted the committee wanted to flag the need for clear articulation of its status at the next meeting. So we've asked for that.
We did that this morning, didn't we?
We did that this morning.
Yeah.
So we can tick that one off. And the committee reviewed proposed changes to standing orders, seeking assurance on how the revisions would strengthen governance controls and how compliance would be measured going forward. Similarly, the committee confirmed compliance with the governance code while noting that external audit attendance should be captured more explicitly within the assessment. And all of that is ongoing. And I've saved you from a lot of papers that are in your standing orders resource section. Internal audit discussions we raised concerns about the timeliness of management responses and the need for the executive's fund commitment to delivering the agreed audit plan without unnecessarily deferrals. Budget setting weaknesses, particularly unsigned accountability letters, were highlighted again as a recurring control issue requiring urgent corrective action via the Sustainability and Recovery Board, and we've actioned that. The committee also wanted to alert the board to limit assurance finding on escalation arrangements and the need for strengthening oversight. We have referred that report to the Performance and Finance Committee. Overall, the committee can let the board know that there's good progress and that there is signalling key areas that require strengthened assurance and clear accountability and timely follow-through have been touched on and highlighted.
Yeah. Very robust, I think, Nuria. Thank you. Really, the committee's coming in an awful lot of ground. So thank you for that. Any comments or questions for Nuria? So we can complete that and take assurance, and please convey our thanks to all committee members, Nuria, and the executive and support team there, because you're clearly on a roll, I think. Thank you. So shall we move on to mental health then, and mental health legislation committee, Anne-Louise?
There are no alerts in the last committee. Assurance that the health board is compliant with the mental health legislation. I will say it's not, it looks as if it's just a rollover, but the various members who made presentations are challenged on some of the figures that come up. So it's not just looking at it and saying, oh yeah, it's okay, it's a tick box, but we are compliant with legislation.
Thank you, Anne-Louise. Board can take assurance on that. Thank you. Nicola, charitable funds.
Thank you, Chair. Just take it as read. So just wanted to highlight one or two things. The charity team have done a huge amount of work in the last quarter of the year, ranging, and they are looking ahead. I have asked if they could look ahead and maybe give board members an itinerary of what's coming ahead. So maybe people could perhaps pop along to some fundraising events. One other thing I wanted to highlight, the job description is now being created for the head of charity, so that's been amended as well. Thank you.
Thank you. So that look ahead would be really helpful, and Hazel, put that into forward look for the board, as you say, Nicola. Thank you very much. And Hazel, the update from the last RJC meeting?
Yeah, so there's no issues to alert the board to. There was one special meeting just to endorse and support the preferred site option for the regional cellular pathology site.
The next meeting is in April, isn't it?
That's right.
Thank you. Can we move on to your report then, Hazel, please?
Yeah, so this report sets out matters the board considered in committee, the Welsh Health Circulars, Common Seal, board work programme, and then as Nuria alluded to, the standing orders review did go to the audit committee. The main changes are the updates to the terms of reference that you're asking the board to sign off. We have brought back a board site visit protocol, and with thanks to Harrod Higgins, his team for developing this. We've got 9 teams going out on a quarterly basis, which over the year would be 144 visits out to our sites. We're also looking at board development sessions being held out in the organisation, and therefore we'll tie them into topics. So 144 would be the minimum board visits that would be undertaken on a quarterly basis, and we're asking for the board to approve the protocol.
Thank you, and that would give us really increased visibility, wouldn't it?
Yeah.
I'm really happy with that.
Yeah,
And
very
thank you, and thank you, Hazel, for the team in putting that together. Thank you. What do we want to do?
Yeah,
Do we want to approve as well
the
SOs and SFIs?
revised, yeah.
We're happy to approve those and SFIs. Thank you very much. So I mentioned at the start of the meeting, we've got a new item in this section today, our public affairs strategy. Really, one of the key components of bringing this now is to prepare ourselves, as I said, for the outcome of the election and the incoming parliament. And we have 16 members of the Senate, 18 members of the Senate, 6 times 3. So it really is incumbent of us to think differently. And so that's part of the wider public affairs strategy. So Richard, obviously the members will have read it, but the key things you want to bring to board's attention.
Okay, I'll pick out some key things, as you said, Chair. So first of all, just to emphasise that this is an enabler. It is about supporting and underpinning our organisational strategy, A Healthier Swansea Bay, and the emerging Transforming for the Future clinical services plan as well. So its role in that would be really important. I think it's worth saying, I think we're starting from a basis of solid foundations with a lot of activity already undertaken, but clearly the time is right to review where we're at and set out clearly why we're doing things. So the purpose of the strategy very clearly is to articulate why public affairs is important for the Health Board, as well as what we are seeking to achieve. So the purpose is, there are four bullet points on that around understanding the needs and perspectives of others. I think that's really important that we're listening, that we are able to shape and influence policy and delivery elsewhere, that we also instill confidence in our plans for the future, demonstrating that we are well run and can be trusted, and also that we demonstrate our accountability via our openness and transparency. There are some principles that are suggested there in terms of being apolitical, clearly, open and honest, that we do listen and act, that we're respectful of partners and their roles, and that we're focused on our population. And then what we want to achieve is that we want to strengthen our Health Board's relationship within the Welsh Government. We want to strengthen relationships with all other elected politicians with a view to managing their concerns and harnessing their influence. We want to build trusted local and regional partnerships, enhance public trust, and demonstrate a wider accountability and good governance. I think, as I said, there are some good foundations, but as the Chair's just said as well, we're also at a moment of big change with the creation of a new electoral system, which will see 18 members of the Senedd going forwards, the majority of whom will be new members of the Senedd. So it's really important that we focus on that and build up new relationships, and much in the way that we have over the last few years in terms of the existing cohort of MSs and MPs. Because that really is important for us in the way that it gives us early sight of issues that appear, but also allows us to be able to address those in a timely way with individuals who represent the views of their communities. So the timelines for this strategy are that we'll focus on the now, so the pre-Senedd elections. We then move on to the short term, so that's immediately post-election. Medium term, which is post-formation of a Welsh Government, and then longer term, which is the glide path to the 2030 Senedd elections. And there are a range of different actions that are outlined in the strategy along those different timelines. Just quickly on the charity is probably underutilised in terms of the way that we can use it within the context of our public affairs strategy, because clearly politicians want to support good causes, and I think that there are a range of good causes that we can put in front of them. And their support would be valuable as well. So that's something we'll focus on. In terms of accountability and resourcing, we'll rearrange our existing resourcing so that we're able to resource our public affairs effort. I think that's really important, particularly given the timing. And just in summary, as I said, the strategy sets out why public affairs is important to our health board and what we're seeking to achieve as a result of becoming more active in this field. And the strategies gives us a clear framework within which our public affairs activities can operate. And then I'll just finish off with the recommendations. So the recommendations are that we approve the public affairs strategy, be assured of its alignment or role as an enabler, and be alerted to the way that we'll resource it.
That's a really helpful outline of a developing approach for us, really, isn't it? Building on some very, very good foundations. And we did have very positive feedback from our members of the Senate and members of Parliament when we had the last briefing for this Parliament last Friday. So many congratulations to you and your team, because you choreographed this and they clearly value it. So thank you. Any comments or questions for Richard? Maria?
I think it's welcomed. I think it's timely, and I think linking it with the charity is definitely positive. I think for me there is an issue around resources. It's very thin in terms of what we need to do, what we want to do, and the resources that we have. Given the level of change in the politics, but also given the level of change of the Welsh Assembly government and the number of relationships that I know the chair, the chief executive, and all of the executives and the independent members have. So I think that there's a question for me about what our measures of success are going to look like, given our objectives, and whether we're clear so that we can actually highlight how successful overall our approach has been. That would be my only comment in relation to the strategy.
Richard?
Yeah, just in terms of the inputs, first of all, it very much is a team effort because in terms, for instance, of the briefing sessions we have with politicians, and a range of different execs are involved in that, as is the chair, the deputy chair. So there's a range of different inputs. We also work closely with the NHS Confed, who are shortly becoming the NHS Alliance. The information that they give us, I think they really ramp that up, and that's very, very helpful. So it's about sort of collating all these different inputs then and the support that's available so that we can actually deliver the strategy. In terms of measuring the impact, I think it's quite a difficult one, isn't it? In the sense of it's not sort of black and white data in the sense of something will be achieved or not. I think it's about the relationships, and it's about people's perceptions of us, and it's about the elected politicians' perceptions of us and their willingness to actually engage with us and give us feedback, and then also listen to what we're saying in response. So it's quite difficult to pin it down. I guess we'll know whether we've been successful by virtue of the nature of those relationships going forwards.
We'll have a look at that. We'll have a look at some impact metric we could perhaps use.
I'm thinking about metrics of influence in particular, because a lot of the work that we're talking about is the influence that we have in terms of strategic direction. So I think there's something around the influence that we can pick up. And then there is something about, for me, something about what you just highlighted, which is there's lots of people involved, which is fantastic, but it's that coordination of effort towards that influence that you want to have.
James, if you want to come in.
Yeah, I think it's a really good start, Richard. Well done to you and the team. My question is from a keep it simple perspective. I read that you were devising a second strategy that addresses the people we serve. I wondered whether from that keep it simple process, we could dovetail that into what you have here.
They very much need to be complementary, Jean. And it's about that wider communications with the population. So in essence, it's about describing that better, being very clear and having it in one place and in terms of a strategy. It'll encompass and reflect a lot more what we're already doing. But I think just actually articulating that would be helpful and give more confidence to everybody that we're doing the right things.
So can we approve the strategy then? And we take assurance as set out there, and we relate it to the, I would say, limited but perfectly formed public affairs capacity. Yeah. So let's move on then to the minutes, and we've got 3 sets of minutes. So firstly, the meeting on the 29th of January. Are they correct by vote, please? Thank you. All right. Okay, there we are. There's some minor changes to who was here and who was not here. So we'll sort that out. Thank you. 17th of February. Special Board and 26th of February. Thank you. So Hazel, would you take us through anything on the action now?
We've been putting up some actions during the meeting as we've actions in place, so we've got 6 remaining open now. I'll gain an update and share them with board members after the meeting.
Thank you very much for that. So then items for noting, we have minutes from our 3 different advisory groups there to receive. And they are sent out, we've had them previously, so we can receive those. And then finally, the report that I produce every month in terms of what I do in terms of getting out and about. And as you know, I don't normally comment on this, but I just want to say, I went to the Healthcare Support Workers Conference that Liz and her team organised, and it was one of the most uplifting, inspiring days I have been to in a very, very long time. I mean, the talent amongst our healthcare support workers, their aspirations, and something I didn't realise is just the breadth of the educational qualifications that they either have or are striving for. And it really did me good that day, I have to say. Thank you.
Glad you enjoyed it. I'll plug the Nursing and Midwifery Conference on 22nd of May as well. Anybody's welcome. We'll send out an invite.
They've had no other business. So at that point, I'm going to meeting to a close. Diolch yn fawr iawn i gyd am eich cyfraniadau, cyfarfod bwysig. So thank you all very, very much for your contributions. It's been a really important meeting. We've covered a lot of really significant, important ground, and we've done it as a unified board with respect, with constructive challenge, and in the interests of the population we serve. So that is a good day's work. So, diolch yn fawr iawn, and see you next time.